is uh, Reconstruction after breast cancer, understanding your options. We have a wonderful medical expert here who is very, very skilled at plastic surgery. She is one bad sister, and we are super excited to have Dr. Camille Cash, who I will introduce in just a moment. But again, today's Patient Education and Empowerment virtual webinar series is Breast Reconstruction After Breast Cancer, Understanding Your Options. We would like to say hello to our Facebook friends who are on Facebook Live watching us, as well as those who have tuned in directly through Zoom. Today's webinar is sponsored by Natrelle, and we very much appreciate Natrelle being a partner with this particular webinar, as well as helping us with Sisters Network and other aspects of our organization. But before I get started, I'd like to bring some greetings from Karen Jackson, who was our founder and CEO. She can't be here today, but she does bring her greetings and well wishes to everyone, and hopes that you enjoy today's webinar. So without further ado, I'm going to introduce Dr. Camille Cash, who is a Howard University alumni from the Howard University. She is also a graduate of Baylor College of Medicine. Dr. Camille Cash has a sincere focus on her patients, and their needs distinguishes Dr. Camille Cash as a plastic surgeon and a reconstructive surgeon. Her practice is in Houston's Upper Kirby district and has prospered due to word of mouth endorsements from patients and referrals from colleagues who trust and respect her work. While a student at Baylor College of Medicine, Dr. Cash developed a strong interest in surgery. She says that I enjoyed being able to heal the body by using my hands. However, it was while on a rotation in plastic surgery during her internship that Dr. Cash found her true calling. She says, I fell in love with the field instantly. I was not only able to cure disease, but to restore beauty and function. Through plastic surgery, I am able to combine artistry and medicine, healing both the body and the spirit. As a mother of three, Dr. Cash can relate to many of her patients because, as she says, I am a woman. Other women feel very comfortable coming to me and talking about their bodies and their expectations. Dr. Cash has a one-on-one approach that is refreshingly different than some other physicians. She combines competence with compassion. You have to think of the patient as an individual and their specific needs in order to provide exceptional care, according to Dr. Cash. Dr. Cash is able to communicate with her patients directly, valuing the personal attention that she gives to all of her patients, whether through preoperative counseling about their surgery or direct calls by herself, the surgeon. A true understanding of her patients, a keen knowledge of the latest technologies and techniques in the field, and an abundant experience enable Dr. Cash to produce the best results for her clients through surgery and the outcomes. Dr. Cash prides herself on minimizing incisions and scarring to produce the best result. She is board certified in plastic and general surgery. And Dr. Cash, by the way, is the only African-American female in the state of Texas with these credentials. So I told you she is one bad lady. She is also a member of the Texas Society of Plastic Surgeons, the American Society of Plastic Surgeons, and the American Society of Aesthetic Plastic Surgery. Dr. Cash enjoys mentoring the residents, in plastic surgery at Christus St. Joseph. Her dedication, training, and skill allows her to heal the body and spirit, as a significant portion of her practice is dedicated to reconstruction of the breast following the treatment for breast cancer. Dr. Cash performs a myriad of procedures and has extensive experience in breast augmentations, lifts, reductions, and reconstructions, mommy makeovers, liposuction, body contouring surgery, as well as facial rejuvenation through the use of surgery, soft tissue fillers, and Botox. Dr. Cash is active in the Houston community as well as running her busy practice. She is an active member of her church and devotes a lot of time to her sorority, which is Alpha Kappa Alpha Sorority Incorporated. Her appointment to the Board of Directors of Sisters Network Incorporated, which we really value her time and expertise that she lends to the organization, allows her to raise awareness of the methods and availability of breast reconstruction to the underserved minority community and to help all affected parties and their families take advantage of this aspect of cancer survivorship. Dr. Cash is married to Roderick Chris Lowe, and they have 3 beautiful children, Lauren, Kennedy, and Christopher, and she's a recent empty nester. I would like to welcome you, my friend, and our physician, our medical expert today, Dr. Camille Cash. Thank you so much for being here today, Camille. We really appreciate, well, Dr. Cash, I should say. We really appreciate you being here today. Your expertise, I know that a lot of folks will tune in and really have a lot of questions. So without further ado, I'm gonna give the floor to you to do your presentation.
Wonderful. Well, thank you so much, Caleen, and a big shout out to Karen Jackson. We miss you, we love you, but we are going to carry on and make you proud. And thank you to Natrelle, who is helping to sponsor this event. I am going to share my screen, I think. I am. Hold on, give me 1 second, because, yep. Share screen, sharing screen, share screen. Okay. All righty. Can you all see my presentation?
We can see it.
Excellent. Okay. So thank you again for that warm introduction, Caleen. Again, my name is Dr. Camille Cash. I'm a board certified plastic surgeon here in Houston, Texas. My practice has evolved over the last 20 years, and it's been a pleasure to serve as a board member for Sisters Network. I find that my practice has evolved where I'm not doing breast reconstruction any longer as a main focus of my practice, but I often have friends, family members, and patients that will come to me to ask about breast reconstruction because it's a very complicated field. And patients just sometimes, I think reconstruction sometimes gets treated as a second or a third aspect of your whole treatment with breast cancer. And so every woman who has to undergo a mastectomy should be given the information she needs to make an informed decision about breast reconstruction. This should ideally happen when the patient is first diagnosed. This should be broached to the patient by either their medical or surgical oncologist so that patients can have the option to decide if breast reconstruction is right for them. But unfortunately, in the United States, not all women have access to the same information or care when it comes to breast reconstruction. And of course, Black women are one of the groups that face the most barriers to getting reconstruction. White women in this country are 24% more likely to have breast reconstruction than Black women, 26% more likely than Asians, Pacific Islanders, Native Americans, and 19% more likely than Hispanics. And these numbers are hold true even when the issues of insurance or location of patients is involved. So oftentimes the thought is, well, Black women don't have insurance, or Black women may live in rural communities where there's not a plastic surgeon. And really that doesn't hold true, because if you hold all things equal, insurance, location of the patients, Black women are still not getting the opportunity to have breast reconstruction in the same manner that white women are. So a diagnosis of breast cancer is overwhelming, and there's a lot of different options, and there's a lot of things that are racing through your mind when you first receive that diagnosis, or one of your loved ones receives this diagnosis. But take a deep breath and understand that your body is yours, and you have the power to make the decision that is right for you. And you have the right to be educated and to ask ask that your providers treat you as an individual. So getting some tips for care that you deserve. Know that you have options. You don't have to take the first doctor's opinion. You don't have to see one plastic surgeon. You don't have to decide that this is the only treatment, or be forced to decide that this is the only treatment for you. You have choices. It is important because, again, it's an overwhelming diagnosis. Know who your patient advocate will be. You will have to advocate for yourself, but it's also important to have another set of ears, and it could be a friend, a family member, another survivor, or a hospital or a facility appointed patient advocate. You need to have somebody that's helping you advocate for your body, your decisions, your choices. Don't be afraid to ask questions, even if you feel like you don't quite understand the material or how to ask the questions in the best manner. Don't be afraid. Ask for a second opinion, a third opinion, whatever. Ask that of your plastic surgeon. Don't necessarily settle for the first recommendation. Talk with other patients who've gone through similar situations as you. Find out what their experience has been, both positive and negative. And sometimes you have to just trust your gut. You're going to be selecting a plastic surgeon who you're going to be spending a lot of time with, and you're going to be turning your body over to him or her. And so you want to have some degree of rapport with your plastic surgeon, as well as all of your physicians. And so I was asked to list a few questions for your plastic surgeons. Well, I came up with more than a few, and I don't think that you should be shy about asking these questions. Ask them, are you certified by the American Board of Plastic Surgeons? How many years of training have you had? How long have you been doing breast reconstruction? Do you specialize in breast reconstruction, or is the doctor more like me, a cosmetic plastic surgeon that doesn't do as much reconstruction? Where will my reconstruction be performed? Is it going to be done at a hospital or a surgery center? Do you take my insurance? Does the hospital, anesthesiologist, the pathologist, all of these entities, do you take my insurance? Am I in network? Am I out of network? This is an important question, ask your plastic surgeon, how often do you work with the breast oncology surgeon? Because if the breast oncology surgeon and the plastic surgeon will work hand in hand, because there's certain nuances of a mastectomy that we'll get into in just a moment that may impact your reconstruction. What type of mastectomy will I have? How will chemotherapy and radiation therapy impact my breast reconstruction? How will do you communicate with my other physicians, and who is going to lead my care? What type of reconstruction is best suited for me? What are the pros and cons of each approach? How long will the recovery and the surgery itself be? How much help will I need after surgery? What are the potential risks and complications of the surgery, and how are they addressed if they arise? How many surgeries will I need? Oftentimes, patients are surprised to find out that breast reconstruction may not be a one and done operation, and it may be something that impacts them for the remainder of their life. So ask these questions and understand up front. You can ask them specifically, how much experience do you have operating on women of color? What type of scarring can I expect? What happens if I don't like it or if I'm dissatisfied? What can I do as a patient to give myself the best outcome after surgery? Ask about what phone calls and paperwork related to getting the surgery covered by insurance the doctor's office is going to handle, the hospital is going to handle, and what the patient has to do. And then most importantly, please ask your plastic surgeon to show you before and after photographs of their patients, not somebody else's, but their own patients. I am amazed that some plastic surgeons may not even show patients before and after photographs, or even take before and after photographs before they embark on a breast reconstruction. So super important. Sometimes women are hesitant to pursue breast reconstruction because they're concerned that it's not going to be covered by their insurance. But in 1998, the Women's Health and Cancer Rights Act was passed that mandates that all group health plans and private insurance companies, including HMOs, pay for mastectomies, pay also for all stages of breast reconstruction. And that can be breast reconstruction that's done at the time of the mastectomy, or breast reconstruction that's done in the future. It's to cover procedures of symmetry, meaning the other breast, the non-cancer side, should be able to be covered, and that any future surgeries, as long as the patient is alive, can be covered. In addition, government-sponsored programs such as Medicare and Medicaid will cover breast reconstruction, but it does vary from state to state. And it may be that you're more limited in finding a plastic surgeon that will accept the government-based insurance. So whatever type of insurance you have, understand what your out-of-pocket expenses would be and who takes your insurance. So there's no surprises in terms of finances down the road. So we're gonna take a little deep breath here, and then I'm gonna get into a little bit more technical aspects of breast reconstruction, and we'll go through some before and after pictures. So really understanding your breast reconstruction and how it's gonna look and how what your options may be is understanding what type of mastectomy will you be having? What type of mastectomy are you a candidate for? A total mastectomy is where all of the breast tissue is removed, as opposed to a partial mastectomy, or also known, this is a partial mastectomy, also known as a lumpectomy, where only the breast cancer and some small amount of surrounding tissue is removed. So for all intents and purposes, I'm going to be speaking today about patients that are undergoing total mastectomies, where all of the breast tissue is removed. And a total mastectomy may be in the form of a modified radical mastectomy, which includes a certain amount of lymph nodes that are in the axilla or the underarm. A radical mastectomy is not something that I think is commonly performed anymore. It removes more tissue. It may be reserved for very aggressive or large tumors, but very rare. And then at the far right, a nipple-sparing mastectomy is an option for women in the appropriate setting that maybe have a smaller breast cancer or patients that have a higher risk for breast cancer in the future, and they're opting to go a preventative or prophylactic mastectomy. And so skin-sparing mastectomies are mastectomies that remove all of the breast tissue through a smaller incision than, say, a radical or modified radical incision. And what this allows is the breast surgeon can peel away the underlying breast tissue from the overlying skin envelope. And the skin envelope is the structure of the breast, the curve of the breast, the fold of the breast that gives the breast its shape. And when the breast surgeon removes all that breast tissue, the plastic surgeon then has to come in and reconstruct or fill that skin envelope with whatever they're using to reconstruct the tissues with. And that can be very important in delivering a more aesthetic outcome. Nipple-sparing mastectomies can be performed with an incision in the areola, or incisions around the, incision in the crease, or incisions around the areola. So it just is important to understand what type of mastectomy am I a candidate for? And that will help guide your reconstruction. And that's why your surgical oncologist should be speaking with their plastic surgeon so that they have a definitive plan. And plastic surgeons tend to work with groups of general surgeons, vice versa, so that the doctors, the two surgeons, should be familiar with each other's work and have a level of comfort and dialoguing with each other. If you find that your surgeons don't communicate, that may be a little bit of a red flag. So different options, I talk about kind of broad categories of reconstruction. So immediate versus delayed. An immediate reconstruction has the advantage of being performed at the same time as your mastectomy. And that means you may potentially just have one operation depending on what type of reconstruction you have. And again, the breast surgeon may be able to preserve some of that skin for the plastic surgeon, so your outcome may be more aesthetic. One of the the disadvantages of an immediate breast reconstruction is that it does require a longer time in the operating room, so it's a longer surgery, and it may or may not affect adjunct treatments such as chemotherapy or radiation. It may delay the onset of those treatments, so you have to understand exactly where your adjunct treatments, if you're going to have them, how it impacts your breast cancer, your breast reconstruction, and how they may affect the reconstruction as well. One of the other disadvantages, I think, of an immediate reconstruction can be emotionally. You know, patients are now forced with having to understand they have a breast cancer. They have to understand how the mastectomy is going to work, and then they have to figure out, do that chemotherapy, radiation, and now a breast reconstruction. And that can be very overwhelming. And so the option, I always tell patients, one major option for breast reconstruction is to do no reconstruction. And that's a very viable and completely appropriate decision for some women. But you just need to be given that option to decline breast reconstruction. And a delayed breast reconstruction is a reconstruction that is performed at a separate time than the mastectomy. So delayed reconstruction may allow you to undergo radiation therapy or chemotherapy prior to reconstruction. It can allow patients to quit smoking, lose or gain weight, which may be more beneficial and may lead to a more successful breast reconstruction down the road. And again, it can allow you to mentally and physically prepare for the next stage in your journey, which can be breast reconstruction. And of course, a disadvantage of a delayed reconstruction is that you have to go back through at least one more operation. And after surgery, you'll have a period of time where you will not have the appearance of you will not have a breast. And that sometimes can be a bit disconcerting for patients to wake up and not have a breast. So that's an advantage of having an immediate breast reconstruction. But whether or not you're a candidate for an immediate breast reconstruction or you'd be better served with a delayed reconstruction is a question that you need to ask both your breast surgical oncologist and your plastic surgeon, with input from the medical and the radiation oncologist as well. Two other big broad categories for reconstruction is an implant-based reconstruction versus a tissue-based reconstruction. So an implant-based reconstruction does not create any additional scars or incisions on your body beyond the mastectomy incisions. The plastic surgeon will use the mastectomy incision and place either a temporary implant called a tissue expander or a final breast implant that can be made out of silicone or saline material. It is a good option for patients who are not undergoing radiation. It's a nice option for patients who have small or moderate sized breasts. But you have to understand that breast implants at some point may need to be replaced in the future. So that does mean that you are more likely to have additional surgeries in the future. It may not also be the best option for patients who have very thin skin or compromised tissue. And the determination as to whether or not you would proceed directly to an implant reconstruction versus the use of a tissue expander can be based on the preference of the plastic surgeon and how successful or how what quality of the chest wall skin or the breast skin is left behind after the mastectomies. So when the breast surgeon does the mastectomy, he or she is scraping away, for lack of a better word, the breast tissue from the overlying tissue, and that removes the breast tissue as well as some blood supply. And so if that skin is a little bit thin or the blood supply may be a little bit tenuous, plastic surgeons may opt not to stress the skin with a full, completely expanded implant, but they may be more than likely to use a tissue expander, which will be a partially inflated implant. It'll allow the mastectomy flaps to heal, and then you'll gradually in the office have expansion of that tissue expander, and then a second stage where the tissue expander will be removed for a final implant. Tissue-based reconstruction or autologous reconstruction uses the patient's own natural breast tissue. So no foreign object is involved, and you won't have to worry about any implant-related issues or future surgeries needed to replace that implant. But there's more incisions placed on the patient's body. Another part of your body may be impacted. The surgeries can be longer, the hospitalization and the recovery can be longer, and the surgeries themselves are technically more challenging, which shouldn't be an issue for a plastic surgeon that has good experience in these types of techniques. So another reason to ask them, how many of these types of reconstruction have you done? Autologous tissue can also be used to reconstruct larger breasts. So that may be more volume that can be achieved than just the use of an implant alone. So the implant-based reconstruction, you can see this diagram here. This is an a tissue expander that is placed underneath the skin, and it's sometimes placed below the pectoralis muscle, although it can sometimes be placed above the pectoralis muscle. The tissue expander is not completely inflated, so you're not going to have the full volume of your breast when you first wake up from surgery, but gradually in the office, you'll have saline through a port that's injected into the tissue expander to expand it. As your skin gets the chance to heal, it can be more safely expanded without the risk of healing difficulties or delay in some of your other adjunct treatment options. If patients are eligible for what's called direct to implant reconstruction, meaning the breast surgeon will do the mastectomy, the plastic surgeon will come in and immediately place an implant, then you don't have to go through the expansion of the tissue expander or secondary surgery. With either type of a tissue expander or implant-based reconstruction, most oftentimes the doctor, the plastic surgeon, will use what's called an acellular dermal matrix. Just think of it as a strip of collagen that's sewn into the tissue underneath the skin to help support the weight of the implant, shape the bottom portion of the breast, but also give a little bit of padding to that overlying mastectomy skin. This is an example of a patient that had an immediate breast reconstruction. She had a pre-breast cancer, so she was eligible for what's called a nipple-sparing mastectomy. And you can see that her incisions are actually, you can't see them because they're actually in the crease of the fold of the breast. This is a very cosmetic appearing breast reconstruction, but it's still not perfect. You can see a little bit of contour irregularities or rippling of the skin from where the where the breast tissue is removed. These little subtle imperfections can be addressed by future surgeries, including fat transfers. And so there's certain options that can be done to enhance the outcome. But this is a very aesthetic outcome for a young lady. She had small breasts to begin with. She actually wanted her breasts to be larger, and so she had that option of getting a larger implant. This is a very different patient that had to have an implant-based reconstruction. You can see that her right breast is, her natural breast is hanging. It's a little bit droopier in this upper picture. This is her non-affected side. This is her mastectomy side. You can see her mastectomy incision is here. She actually at the time had an areola sparing mastectomy. So this preceded nipple sparing mastectomy. So a little bit of pigmentation, skin pigment that gives a little bit more of a aesthetic outcome to the breast. The first stage is to put a tissue expander in. The tissue expander is slowly expanded over time. And then at the second stage, the patient undergoes a breast lift on this side to more closely match the implant reconstructed side. Now this tissue expander has been removed and a more permanent implant has been replaced. But you can see part of the downside to an implant-based reconstruction are rippling or contour irregularities in the surface of the skin. Again, this can be addressed with fat transfers, but is one of the downsides to an implant-based reconstruction. No other incisions outside of her body. Everything's based on the chest wall. There's another step up that uses both an implant and tissue to reconstruct your breast, and this typically uses the muscle from the back called latissimus dorsi muscle, where a portion of skin can be moved, skin and muscle can be removed from the back and rotated to the front to reconstruct the breast, and you have a skin paddle, and underlying, because the back muscle is not very full, it doesn't have a lot of volume, an implant can be used to create the volume in the lift, in the projection. This is a woman that presents for a delayed breast reconstruction. You can see she's had her mastectomy years ago. This is a modified radical mastectomy where lymph nodes were removed. Skin envelope was removed. The lower skin was completely removed. The patient did not have to have radiation or chemotherapy, but she's left with a deficit of skin. So in this situation, an implant-based reconstruction may not have been a best option because I wouldn't have been able to use as large of an implant as I would have liked, and I may not have been able to recruit enough breast tissue to make that breast as symmetric to her other side. This is now her after her latissimus dorsi. This is this is skin and muscle from her back, gives her a bigger skin paddle, and that allows that breast to be shaped. On the other side, she has a breast reduction, so she's in much better symmetry. You can see her before of her back and her after. So I used a large incision to create, to remove as much skin so I could create the breast on the front. So with an autologous tissue, again, there's incisions and scarring in another portion of the breast, but allows me to create a larger breast, a smoother contour to the breast so you don't see the rippling from the implant because you've got muscle and fat from the back covering that implant. I use the implant to create volume. And then patients can decide down the road if they would like to have a nipple areola reconstruction. Now, complete autologous breast reconstruction can utilize tissue from your abdomen, tram flaps, transabdominal rectus myocutaneous flaps were an older technique where we used to take muscle and skin from the lower tummy to reconstruct a breast. And in some communities where microsurgery may not be as standard of care, it can be a very viable option. But in tertiary care centers and in larger settings, less muscle is being taken. So now we have these microsurgical procedures that are using perforator flaps. And perforators are just blood vessels that go through the muscle to the skin and to the underlying fat. So plastic surgeons don't want to take any muscle from your tummy because that can leave you with a weak muscle and a weak abdomen. So now they're using perforator flaps where they're taking skin and fat and blood vessels from your tummy and moving that into the breast, and then using a microscope to connect the blood vessels from the abdomen to the chest to create a breast that is all your natural tissue, that is perfused with blood, so it's warm, and can create a larger breast, a breast with a little bit more droop or hang. The DIEP flap, or the deep flap, is very common because oftentimes women may have some redundancy in their abdomen from having children or not, and it can usually have enough tissue to reconstruct a breast. Other options, if say you've had a tummy tuck, or maybe you don't have enough volume in the tummy, or you've had a failed reconstruction, other parts of the body now are being used as well for reconstruction, and it can be from the lower thigh, the inner thigh, the upper buttock are different areas where breast reconstructive surgeons can take your tissues to reconstruct your breasts. And so these are two examples of patients that have undergone autologous tissue reconstruction. So this is a patient that had the perforator flap. So fat and skin are taken from the lower abdomen. She has an incision from hip bone to hip bone, similar to a tummy tuck. That muscle and fat is then inserted into the breast, into the chest, and the blood vessels are sewn to blood vessels that run along the sternum. And you can see this large skin flap creates a nice breast mound, and then the surgeon is able to come back and reconstruct a nipple and a areola. The other breast on the contralateral side undergoes a breast reduction so that they can be more symmetric. This is a different type of reconstruction where skin and tissue is taken from the inner thigh. And you can see that both thighs were utilized to reconstruct both of her breasts. And there may be, she didn't have a whole lot of tissue in her abdomen. Perhaps she didn't want to have an incision in her abdomen, or her plastic surgeon felt that this was the best place for her to have tissue taken from. And then you can see where her skin paddles have been placed. Her nipples have not yet been reconstructed. So breast reconstruction, understand your options. That's just a very kind of breast reconstruction 101. But as you can see, you have options. You have options in what type of treatments you undergo, which surgeon you use. But you have to educate yourself, empower yourself, advocate for yourself. Don't be afraid to ask questions. Ask for second or third opinions. Ask for those before and after pictures. How many Black women have you treated? Can you show me some of their pictures? Talk to other patients who've gone through similar experiences. And again, trust your gut. And with that, I will end my presentation. Thank you so much.
Thank you, Camille. Thank you, Dr. Cash, for that presentation. It was very informative, and it's always good to see before and after images. I know that you touched on a couple of things for people to ask their doctors. If you could tell someone the top, maybe top 3 or 4 suggested questions that are just like a must. I mean, I know there's a lot of questions to ask, but before you walk out of that door, these are some of the 3 or 4 questions you'd like to see your patients maybe ask you, for instance.
So 3 things. How much experience do you have? What different types of reconstructions are open to me, and what's the best one that you can, and that's going to be one question. What's the best one that you would recommend for me? And then what are the potential risks and complications? What if everything goes right? What if things don't go as well as planned? What happens then? And of course, before and after photographs.
Okay, great. Can you stop sharing your screen too for us when you have a chance? I know that in the chat, we've put in a couple of resource website, surgery.org and plasticsurgery.org are two good resources. And if you could expound on why you're suggesting our viewers check those out.
Sure. So those are two websites that are launched by our two main plastic surgery societies in this country. So they will go through all types of breast reconstruction. They will ask before and after photo. They'll show you some before and after photographs. They should show you some patient testimonial videos. They will discuss options, potential risks, and things of that nature in a very unbiased way. They may also have links to breast reconstructive surgeons that are listed in their website, but they're not going to represent any one surgeon. The other thing that I like is that it's going to talk about autologous tissue as well as implant-based reconstruction. And I looked at those sites today. Don't be dismayed. It's a little disconcerting and disappointing that they don't have patients of color represented. I've been a big proponent of representation in the field of plastic surgery, both aesthetic and reconstructive for women of color. I will give a shout out to Natrelle. Their website will deal specifically with breast implant reconstruction, and they do a better job, I think, of presenting a diverse clientele. But just because you don't see somebody that looks exactly like you doesn't mean that you do not qualify, that you should still have the opportunity to have a reconstruction.
Okay. And I know Bernadette's going to start throwing some of the questions that are being put in the chat, and I'll turn it over to her in just a moment. But I will encourage everyone to please put questions in the chat for Dr. Cash. This is your opportunity to talk directly with a very experienced plastic surgeon who is very talented and can just give you some general educational information. I also, since our audience is, we are a breast cancer organization, as you know, I guess you touched on one area that I think is important is like, will reconstruction interfere with chemotherapy or radiation? Because I think that's an important, subject matter to talk about just briefly.
No, most definitely, because breast reconstruction can affect your adjunct treatments, and your adjunct treatments can affect your breast reconstruction. So again, this is why mammograms and early detection is so important, because the stage that you present with will often dictate, will you need radiation? Will you need chemotherapy? What reconstructive options are open to me? So if you have a more advanced or a larger breast cancer, that doesn't necessarily mean that you can never have breast reconstruction, but it may mean that at first you might have to go through chemotherapy and radiation up front. If you, and I alluded to this, it's not best case scenario to radiate a reconstructed breast. Because what radiation does is radiation causes shrinkage of the blood vessels in the skin, and that kind of starves the cancer cells of oxygen. So that's how one-way radiation works. It deprives the residual or microscopic cancer cells of oxygen, but it also deprives your skin of oxygen. So skin can be more fibrotic, it can be stiffer, it may not move and flow as well as your natural breast tissue. The nice thing is your breast may not droop as much in the future after radiation, but I don't think that should be a reason why you have radiation. And so if you radiate an implant after you've had a reconstruction with an implant, then you may be more at risk of having scar tissue around an implant called a capsular contracture that can make that breast even firmer. So ideally, we don't radiate implants. Also, we've found that even if you have an autologous reconstruction, meaning we're taking skin, and let's say we're taking skin and a fat from your tummy, and you make this beautiful breast, and then afterwards, then you have to have radiation, that beautiful breast may then contract and shrink, because even though it's reconstructed, it'll still be subject to the effects of radiation. So there is an opportunity sometimes where plastic surgeons will put in a tissue expander at the time of an immediate reconstruction. and putting a tissue expander in allows the skin envelope of the chest to be stretched and saved, and some of the curves of the breast preserved. Then the patient may have that implant deflated, go through reconstruction, and then immediately after, have that implant deflated, go through radiation. Then immediately after radiation, have that skin wall stretched before it has a chance to contract, and then come back in and do an autologous reconstruction, because you've preserved the surrounding skin, and now you can fill that skin with autologous tissue. And we find that autologous tissue reconstruction will do much better if you don't radiate it, so it can be placed afterwards. So there's lots of different nuances for patients.
Okay, I'm going to turn it over to Bernadette, because we're getting a lot of robust questions in the chat, and I want to try to get as much as we can get in the next 15 to 20 minutes, because that's about all we have. So let's throw some questions to Dr. Cash, and we'll put the survey up in about 5 or 10 minutes.
Okay, thank you, Caleen. Dr. Cash, have you had any patients that have suffered from breast implant illness? If so, what percentage of patients have you seen that happen with?
So breast implant illness is something that's become more talked about in, I guess, in society, and it is difficult to completely understand, because there is not a diagnosis or a test that can be used to determine if a patient has systemic illness, systemic symptoms that are being caused by their breast implants. So breast implant illness is a kind of a general term that some women use to describe systemic complaints such as memory loss, joint pain, fatigue, or other non-specific symptoms that they believe are related to their breast implants. There's not a single test that can be used to diagnose breast implant illness. And so it can typically be, you have to go through a workup to make sure that there's not another disease process or diagnosis that's causing these symptoms of mental fog and things of that nature. And so that is not something that's just easily understood, but it is something that can be, patients can complain of symptoms with their breast implants.
Okay. Is there a recommended timeline for having expanders in before making a final decision concerning one's option for breast reconstruction?
Minimally, surgeons typically will wait at least 6 to 12 weeks after the placement of the tissue expander to place a final implant. But again, there may be different factors involved, including whether or not you need to have radiation, whether or not your final reconstruction will be used with an implant or autologous tissue. So I've seen patients, most patients come back minimum of 12 weeks or 3 months after the initial surgery, but there's sometimes patients will spend, have their tissue expander longer based on family constraints, cancer diagnosis, things of that nature. There are 2 different types of breast tissue expanders. One has a magnetic port in it, and one does not. And so those tissue expanders that have magnetic ports may make it more challenging or impossible for women to have MRIs. So there can be different reasons why you want to get that tissue expander out quicker.
Thank you. What kind of implant do you recommend?
So there are 2 different main types of breast implants, saline filled implants and silicone gel filled implants. The difference is both of the implants come with a silicone outer shell. One type of implant is filled with salt water or saline. It's the same type of fluid that's put directly into your IV and directly into your veins. The other is a silicone based implant that uses a silicone gel. There's pros and cons to each type of implant. Saline implants tend to be have a little bit more of the waviness or the rippling that you can see through the surface of the skin. Silicone gel implants tend to be more natural appearing, have less rippling, and feel a little bit more like a natural breast as opposed to a water bag or an implant that's just filled with water.
Okay, thank you. Dr. Cash, do men who have had breast cancer have reconstructive surgery on any level?
They can, if they have, depending on whether or not, for man having breast cancer surgery, We're typically not worried about reconstructing volume of the chest, as a woman's breast is larger. But men, if they have a defect in their chest after surgery, or if they have a loss of skin or the nipple areola, they can be a candidate for reconstruction as well.
Thank you. Here's a comment and question after. Thanks so much for sharing all this knowledge with us today. I'm a 3-time cancer survivor, all within the last 7 years. Breast cancer, metastatic breast cancer, brain tumor, currently on chemo, 63 years old. I've had reconstruction twice from same African-American male plastic surgeon, and I'm still messed up. What should I do at this point to feel satisfied or more confident? I'm willing to try one more time.
Well, I, wish you success and give you prayers and strength to go through yet another round of breast cancer. And it's difficult to address exactly what your specific needs can be. It sounds like you've had recurrent breast cancer, you've had metastatic disease, you've had a brain tumor. And so oftentimes the presentation of the tumor, the treatments that you have to undergo to first address the breast cancer can affect your reconstruction. And so, unfortunately, breast reconstruction is not always perfect. In even the most experienced hands, there are potential risks and complications. And I will say that breast reconstruction is not for the faint of heart. It does require additional surgeries. It may require surgeries going on and off for a good portion of your life. And so I would say you really, talk to your current plastic surgeon. You may also seek out the opinion of another plastic surgeon or two, because you might find that another plastic surgeon will give you a different treatment plan. Or you might find that that plastic surgeon says, he did everything right. And these were the reasons why the plan was followed and why you maybe did not have the best outcome.
Thank you. I had a DIEP on both breasts last year. One had to be taken off due to finding out I had breast cancer again. How long do I have to wait for another DIEP?
So you are not eligible to have another DIEP flap because they've already removed all of the tissue and the fat from the tummy. And so I would say that you have to consult with your medical and surgical oncologist to find out when you are cancer-free and when you're eligible to have another reconstruction. And then it may be that the plastic surgeon decides to use another part of your body to reconstruct the breast that you lost. And so it may be tissue from your back, your buttocks, your inner thighs. Those are other options. But once the tissue from the tummy has been used, if it's been lost or had to be removed, then you can't go back to the tummy.
Okay. On the reconstructed breast, how long does it take for the feeling, the sensation to return on that side?
That's an excellent question.
It's a question for me.
So, excellent question. I would say that partially depends on what type of mastectomy did you have, and what type of reconstruction that you had. With the mastectomy, even when they're doing a nipple sparing mastectomy, which is the least amount of tissue that can be removed, the breast surgeon is going to be removing the breast tissue from the skin, and also, unfortunately, be removing cutaneous nerves as well as the sensory nerve to the nipple. So in those types of reconstruction, you may never regain complete sensation. It may be altered or decreased. If you have an autologous breast reconstruction, there are some breast reconstructive surgeons who are also using flaps and not just hooking up blood vessels, but also reconstructing the nerves, or hooking up the nerve that controls the sensation of the, so say you're taking skin from the tummy, a DIEP flap. They'll find the inferior epigastric nerve, artery, vein, connect that to the chest. And the blood vessels, the flow starts immediately because, blood's going to rush in and rush out. With the nerves, even though they've reattached it, it may take a year for that nerve connection to heal. And so that is an excellent question for your plastic surgeon. And that's another question that you should put on the list is, and I think I said, what will my breast feel like? What will my reconstructed breast feel like? But also, will it have sensation? So if you feel your breast, that's one thing. Like, what does it feel like? Does it feel soft? Does it feel firm? But also the other question is, will I have sensation or not? And the plastic surgeon should be able to answer that question. Most oftentimes, unfortunately, sensation is lost.
Okay.
These are some
But there
really,
are,
really great
yeah.
questions, really great questions. Someone just asked, how can you know if how can she know if her expander has a magnetic cord? She said that she had it inserted several years ago.
Ask your plastic surgeon.
Okay.
That's the best way.
Just so everyone knows, the survey has been put up. I'd really appreciate if you all would take a moment. It's a few, maybe 6 or 8 questions, just so that we can gauge how we're doing, and the information that we bring to you is very important for us. You're watching breast reconstruction, understanding your options. Dr. Camille Cash is our guest, and Natrelle is our generous sponsor for this afternoon's discussion. We have a couple more questions. Again, please do the survey. I'll do this next question, and I'll turn it back over to you, Bernadette. This person had kind of more of a comment, but I think it's important. She said, I had radiation 2 different times with my breast implants, 2004 and 2006, had one removed and replaced after radiation, just had implant removed a year ago due to severe pain. Doctor stated had to scrape it off her ribs and muscles, and also had chemo twice. She's decided not to have any more breast implants. The pain was just too much. Thank God she's still here. I just think it's important to add that other aspect of, some of the things that people do go through.
Sure. And I think that's important to understand that, and I touched on that. Breast implants don't do well with radiation. And so if that, and the treatment of breast cancer has evolved through the years. I mean, Halstead's radical mastectomy is no longer, we're not even doing that anymore. Modified radical mastectomies, we are not doing that frequently either. So sentinel lymph node biopsy is become the standard of care for most situations. And again, I can't speak to each individual case, but I'm talking about in general. So if you've had a reconstruction and you had an implant-based reconstruction and you find out later that you have to have radiation, you can still give it a try, but at much higher risk of that capsular contracture, meaning that the body, no matter if you're if it's a breast augmentation for cosmetic purposes or reconstruction, your body is going to form a capsule around that implant. It'll be a barrier, just a little bit of a kind of a little fence that the body says, okay, you're a foreign object, and this is natural tissue. That's called a capsule. That occurs if you have a breast implant. It occurs if you have a pacemaker. Your portacath will have a capsule around it. It's what happens when a foreign object is inserted into the skin of the body. So with radiation, that capsule, which is kind of surrounding that implant, can shrink wrap around that implant. So that implant can become firm and hard and sometimes displaced. And especially if you don't have any breast tissue on top of it, it can be quite painful and quite uncomfortable. And the doctor talking about scraping it off of your ribs, meaning he's not scraping the tissue expander per se, but scraping off that capsule because the capsules are between the ribs and the implant.
Dr. Cash, can cancer grow or tumor grow on the reconstruction side?
So the cancer should not grow in, say, the fat of the stomach, because the fat of the stomach doesn't have breast cells in it. So breast cancer arises from breast cells. So ideally, a mastectomy removes all of those breast cells. However, there can be small amount of breast tissue that's left underneath the surface of the skin. Or if you have microscopic disease, then that can recur, unfortunately, sometimes in the skin of the chest that's left behind. So not typically in the fat cells that's moved from the tummy, for example, if that makes sense.
Okay. Do you recommend having a mammogram on the reconstruction side?
Typically, mammography, if you've had a total mastectomy, typically mammography is not needed. You may have to have some other type of imaging studies, such as ultrasounds or MRIs. In rare instances, your breast surgeon may suggest a mammogram, but typically you won't have to have yearly mammograms after you're having a reconstruction, as long as your entire breast has been removed. Now you will still have to have a mammogram on your other breast if you still have natural breast tissue. If you've had a lumpectomy or a partial mastectomy, you will still need to have mammograms. But if you've had a total mastectomy, then you should not need to have yearly mammograms on the reconstructed side.
Okay. Is there an increased challenge if you delay reconstruction?
There can be some challenges, but not as, I think if you plan to have a delayed reconstruction, I think it's much better to plan it with a plastic surgeon in mind, or with the plastic surgeon, because there are subtle nuances that the breast surgeon can do at the time of the mastectomy that will make your reconstruction more favorable down the line. So in the old days, when patients would have a modified radical mastectomy or a radical mastectomy, all of the skin was removed. And then you were left with a very tight chest wall. And having to come back and reconstruct that meant that you might have to use tissue expanders to expand the skin envelope, or take a big, what we call skin paddle, from your tummy or your back to recreate the breast folds. And so I showed you some before and after photographs of patients that have had delayed reconstruction, and you can still have a very aesthetic outcome, but it may mean that you need definitely autologous tissue and maybe a bigger skin paddle versus using kind of the shaping of your own natural breast. But it just depends on the individual as to whether or not that would make it more complicated. Radiation, I will say, does always make reconstruction a little bit more challenging.
Mm-hmm.
I'm just going to jump in out and ask everyone to please do the survey. It's up for a few more minutes, and we're going to be wrapping up in about 5 to 7 minutes. So I think we have a couple more questions, Bernadette, that are being submitted.
Dr. Cash, who talks to the patient about a health nutrition plan to follow for better healing?
That's a good question. You can ask your plastic surgeon, you can ask your surgical oncologist, you can ask your patient advocate about additional information about nutrition.
Okay. Can you please address scarring treatments?
Sure. So African Americans, we do have an increased risk for developing pigmented scars, meaning darker scars. We have a risk of developing elevated scars or hypertrophic scars, and in some instances, keloid scars. And so the difference between a hypertrophic scar and a keloid is that the hypertrophic scar may be an elevated scar, but that's still in the confines of the actual incision. Whereas a keloid is an overgrowth of scar tissue that goes beyond the borders of the original incision. Hypertrophic scars can be treated with steroid injections in the office, silicone taping, and have resolution of those elevated scars with injections, and oftentimes with more time. Keloids, however, can be extremely challenging to treat and may be more resistant to those methods, and may require more aggressive forms of treatment to address, to reduce the risk of keloid coming back.
Okay. On an average, how long can you delay reconstruction after having a mastectomy if you're wanting to do a tissue-based?
I don't think that there is a time limitation. I have had patients that came back 20 years after their mastectomy to have their reconstruction.
Oh, wow.
You don't have to wait that long. And I'll be honest with you, I think the reason she waited so long is because she did not have a plastic surgeon that she felt comfortable with, and she may not have even been given the option for reconstruction at the time of her diagnosis. So it's not too late. There may be different challenges or there may be different implications, but if you have not had a reconstruction and you're interested, then speak with a plastic surgeon and they can give you your options.
This has been a very robust conversation, and everyone's in the chat saying how informative, and spot on your information has been, Dr. Cash. I think we'll have time for a couple more quick questions, and then I want to just do a couple of housekeeping announcements for everyone while we have folks on here. I did see one question about breast lift and nipples. Did we already address that question? It was kind of far up. Can breast lifts affect the nipple? I'm not sure if we ever addressed that question or not.
So that's a great segue. So we could talk about the contralateral breast or the other breast. So oftentimes patients will have a breast cancer on one side. They may not have breast cancer on the other side. And so they may just be looking to treat the side that has the breast cancer in it. And so that means if you reconstruct the breast cancer side, what happens to the other side? Do you do nothing to that other side? Do you want to make the breast lifted to match? Do you want to make it smaller? So a breast lift can be done on your native non-affected breast to match the symmetry of the reconstructed breast. There are some potential healing issues with the breast lift by itself, but typically it is pretty low risk of healing issues with a mastectomy. With a breast lift, a mastopexy, unless you have some other risk factors. I will also say, if you smoke, that oftentimes will eliminate you from being a good candidate for breast reconstruction. And the reason that is because smoking, the nicotine in cigarette smoke or in vaping or in hookah or in nicotine gums, for example, the nicotine shrinks the microcirculation to the skin. So it causes blood vessels to contract. When you go in, you do a mastectomy and you're already disrupting some of that microcirculation. If you're a smoker, that is going to put you at an increased risk for wound healing issues or skin loss because of the cigarette smoking in combination with the mastectomy. So that is why in the presentation, if you do smoke and you want to have a breast reconstruction and your plastic surgeon says you're not a candidate because of the smoking, you may opt for delayed reconstruction. So that gives you a chance to have the breast cancer surgery in a timely manner. And then you can have time to stop smoking and be healthy, and then be able to have a reconstruction that is going to be less likely to have complications.
Okay. Let's take this last two questions. This one says, I currently have expanders now. I saw online there is some kind of skin graft procedure to make nipples. What can make you a candidate for this type of procedure? I have my nipples removed and want to know if there are options available other than tattoos.
Sure. So just again, depends on your surrounding tissues. So patients that have had implant-based reconstruction, oftentimes the mastectomy incision can be right at the level of the nipple. If you're a little lucky, then that mastectomy incision could be a little bit higher or lower than the nipple on the other side. And so you can use skin around that incision that can be a little bit less traumatized by the scar of the mastectomy. So it's a little bit harder if your nipple needs to be placed right in the middle of that mastectomy scar because you don't have as good of a blood supply. You can take skin grafts from, typically we like to use inside the inner thigh, a little bit darker than the skin of the chest. You can use that as a skin graft to reconstruct your areola and nipple. For patients that are having autologous reconstruction, that's what that skin paddle is left behind, and skin nipple reconstructions can be quite robust with it after an autologous reconstruction. But don't sleep on some of these tattoos, because there have been some pigmentation artists. They're artists now that can make 3D nipples, three-dimensional nipples, just with the use of
Wow.
tattooing. So that can be an option for patients as well. And you can get, if you find a skilled pigment micropigmenter, they can really make a very a genuine looking nipple. So I think that I definitely feel that tattooing nipples has come a long way in the last 20 years.
Yes. We have one of the participants that live in California and would like to know if you are taking referrals from other states.
Sure. So again, I am happy to be a board member for Sisters Network. I lend my expertise, but I am no longer doing breast reconstruction in my practice, and I'll explain a little bit why. When I did my training, I didn't do microsurgery. I did a little bit of it, but not a lot. That I trained about 20 years ago, and I started doing breast reconstruction in my practice. And as the microsurgery techniques have evolved and have gotten really, really almost the standard of care, I deferred to my colleagues who were more experienced in microsurgery and can offer that to their patients because you know, that is a huge part of breast reconstruction. So unfortunately, I'm not doing breast reconstruction in my practice any longer. But I would be happy to try to connect you with some plastic surgeons in your area that are. And I often just, I'm kind of like my friend's big sister, you know, they'll call me and they say, what do you think about this? And what are the questions you would ask? And, you know, and that's kind of how my role is for sisters and for you all, is to be a resource and an educator so that you all can find the best plastic surgeon to do your reconstruction. Because I recognized years ago that there were people who had better experience with it than I. So I'd rather you see a white or Hispanic plastic surgeon that does a better job than me just because I'm African American. So just know that looking sometimes for the best doctor out there. I mean, look, plastic surgeons were underrepresented in the field. You know, doctors are underrepresented. 13% of the American population is African American. About 6%, I think, is the current number of doctors are plastic surgeons. About 3% of plastic surgeons are African Americans. So there's not a whole lot of us, unfortunately. I'd like to work as a resource and as a guide to help you all make the best decision possible.
Thank you, Dr. Cash. This has been amazing and so informative, and like, you know, someone said, spot on with the information. And we thank you for your time, and most importantly, for serving on Sisters Network Board of Directors for many years and being a friend and an ear to sisters. Thank you, everyone who took the poll. Just want to thank our team and thank everyone on a Saturday for coming again and listening to Sisters Network, for supporting us, for being involved with the organization for nearly 3 decades. Started with a vision of someone being diagnosed with breast cancer, trying to make a difference, and we continue to evolve. And so we just thank you. We hope that we continue to do the good work across the nation to help women who are survivors. And having someone like Dr. Cash on today is just an example of the level of experts and friends that we have in the medical community that can lend their information and resources. Again, to our Facebook Live friends who have been tuning in, we thank you. And we have a couple of upcoming events. I just want to share some information. We do have mammograms that are free, they're being paid for by Sisters Network nationwide. If you go on our website, you will see the application. We have Mrs. Jackson is, which did you put it? Okay, Mrs. Jackson's book is, okay, I'll talk about the town hall since that's up right now. The town hall is going to be October 16th during Breast Cancer Awareness Month. We're very excited about this. We feel that there is a crisis with Black women and breast cancer in America. We have some major speakers. As you can see, a lot of supporters, a lot of partners. Dr. Cash, you see Howard University alumni is part of this, Spelman, TSU, Sigma Gamma Rho, the Links Incorporated. Black Health Matters, with Top Layers of Distinction, of course, our corporate friends that are part of this. So it's going to be a big event, October 16th. If you haven't already registered, please do. The link is on our website. We thank Natrelle for today, for bringing and making this conversation possible. And again, Dr. Cash, thank you so much. Mrs. Jackson, her book is available on Amazon, and she is offering a 10% discount through the end of October. So if you go on Amazon, just Google Karen Eubanks Jackson, and you will see her book. And it kind of tells you the story of Mrs. Jackson in the company of her sisters and founding the organization back in 1994. And fast forward today in 2021, we are still in existence. Our footprint is large and powerful. And it's because of not only Mrs. Jackson's vision, but the chapters who are around the country doing the good work. And I saw some of our chapter members on that are very dedicated in doing the work in the various cities that we are located in. So we thank you for your time and support that you give to Sisters Network on the ground. The boots on the ground are what makes Sisters different from other organizations out there. And finally, I'd like to thank all of our team today who works on these webinars on the weekends, Shadala Jackson, Bridget Holden, and Bernadette Jackson, who was fielding a lot of the questions. I thank you ladies for helping make today possible. Someone did ask, will this be repeated? We always put our webinars on Sisters Network website as well as on YouTube for post viewing because the information is so useful. We want to make sure that if you didn't have a chance to see it and you want to share it with a friend, that you can, or if you missed something and you want to go back and look again, that it's there. So we thank you all. Everybody have a great Saturday, the rest of the weekend, enjoy. And thank you, Dr. Cash, thank you, Natrelle, and thank you everyone for taking your time on a Saturday to make your health a top priority. Sisters Network is here to serve you. Please call us or email us anytime and we will try to help out. Thank you.
Thank you.
Take care.